So this afternoon, at the end of the day, we're going to continue to talk about covariate items that have a direct impact on pressure ulcers that are new or worsened. So as we move along, we're going to be looking at, first we'll start with a reminder that coding in this situation does not, oh, look at that, my pages are out of order. See that? It's the end of the day for me, too. Okay, let's start by looking at the objectives. Aside from making it through the next hour and 15 minutes and getting to the happy hour, we're going to have a working knowledge of 1028, the active diagnoses, comorbidities, and coexisting conditions, 1060, height and weight. Both of these are new and being added into the OASIS. We're going to look at 1620, bowel incontinence frequency, which is not new, but does have an impact. We're going to be able to articulate the intent of 1028, 1060, and 1620. We will look at different response options for each of these, and we will understand and apply the instructions so that we can accurately respond to the practice scenarios. I want to remind everyone that once again, the terms code or coding, as we use them in this training, refer to how you respond and code or score the OASIS assessment items. We don't want you to confuse this with those wonderful people who understand ICD-10 coding, one of which is not me. Now let's talk about these pressure ulcer covariates. These items in the OASIS set are risk adjustment covariates for the percentage of patients with pressure ulcers that are new or worsened. This is a quality measure. As I said, there are three: 1028, active diagnoses, 1060, height and weight, bowel incontinence frequency, those are the three we're going to talk about now, and GG0170C, lying to sitting, that Anne has gone over with us. 1028, the active diagnoses and coexisting conditions, and 1060, height and weight, are new to the OASIS C2. They are going to be in the time points of start of care and resumption of care. 1620, the bowel incontinence, has not been modified or changed in any way in the OASIS C2. This item is completed at the start of care, at resumption, at follow-up or research, and at discharge from the agency, but not when the patient is going to an inpatient facility. So let's begin. We'll begin by looking at 1028, the active diagnoses, comorbidities, and coexisting conditions. Here in front of you on the screen, you see the item exactly as it is written. Why would these be covariates? How do they impact the risk of pressure ulcers occurring or worsening? Clearly, anything that involves impaired circulation, like peripheral vascular disease, peripheral arterial disease, is going to have an impact on the condition of the tissue, on its nutrition, and it's going to have an impact on the tissue's ability to heal. Diabetes is also going to impair circulation. It's going to impact tissue nutrition, and it is well known for its impact on healing itself. The intention of 1028 is to identify whether or not these two specific diagnoses are present and active. They influence the patient's functional outcomes or increase their risk for developing or worsening of the existing pressure ulcers. While there are only two selection items There are actually 3 separate disease processes that we are looking at here. What is the rationale behind selecting these? As clinicians, regardless of your discipline, we know that the disease process can have a significant negative effect on an individual's overall health status and their quality of life. We need to identify the active diagnoses that are directly associated with this home health episode of care for the patient whom you are assessing. Remember, start of care, resumption of care, specifically after an inpatient facility discharge at the time the agency becomes aware that the patient has returned home. This is addressed, the definitions for SOC and ROC, in the frequently asked questions. This is a 2-step process. We need to first identify whether or not these diagnoses are present. And once we know that they are present, we then need to follow up and determine whether or not they are active, bearing in mind how we have defined active. Active is having a direct impact on the patient's current functional status or the activities that the nurse is going to be performing. So how would we go about identifying the diagnosis? You're going to be doing that by making sure that you are only checking this off if one of these 3 disease processes has been confirmed and documented by the patient's physician or a nurse practitioner, a physician assistant, clinical nurse specialist, or someone authorized and licensed as allowed by your state licensure laws. Only their input can be considered in determining whether or not this particular item is present. You must always look at your state licensure laws so that you are sure that this is a discipline or an individual whose information you can accept and use as part of the assessment. So what documents are you going to be looking at? You've identified the primary physician. You've spoken to an APRN or a PA in that practice office. What other documents or resources can you use? When you accept a patient's referral, and that referral is coming to you from an inpatient setting, from an acute care setting, you should be receiving a full packet of information. It has transfer documents, physician progress notes, an H&P, a discharge summary. In many instances, they have a document they call the course of clinical care. Every institution or group of institutions has a different name, a different title. What you're really looking for is that document that says, so-and-so was admitted on this date, they were here for so long, they had the following tests, the following labs, the procedures were done, here's the procedure report, here's what we found, here are the diagnoses, here are the meds, here's my discharge plan. And do I think they can really accomplish that discharge plan? Whatever they call that document, that's what you need to get your hands on. It will include the orders and the orders for your services. It should also have any consults or other official diagnostic reports, like that surgical summary, like that report from radiology on the CAT scan, the PET scan, the MRI. You need those documents. That's where you're going to find the information you need as to whether one of these 3 disease processes are present and being part of the plan of care. So think about that. When your referral information comes in, look for those documents. When the referral comes to you from a rehab facility, from a skilled nursing facility, a long-term care facility, if that patient has been in the hospital before they went there, that facility has that documentation. And you want to get that from them. Because if the hospital stay was 6, 8 weeks, maybe 3 months ago, when you call and ask their discharge planning office, they're going to snicker all the way back to the water cooler. They're not going to be able to go look for it for you, and they're not going to be interested in taking the time to do it. They have way too much to do now. But the long-term care facility has it. It's sitting in their chart. When they call you to give you the referral, get it from them, but make sure you get it. When you get a referral from a physician's office, ask for at least the last 2 visits. They have electronic records. You're going to find that where in the past, just taking the referral over the phone from the physician's office, you might have gotten the 90-second, take this person and get them off my phone. Now, with the last couple of visits from their electronic record, you've got the complete list of medications. You've got the complete list of diagnoses and what the physician's been focusing on. So this is going to make a significant difference for you. So once you have all of these documents, this is going to give you the ability to determine, as part of the start of care admission assessment, whether or not one of these 3 disease processes is present and active. As you read the material, it's quite possible you're going to see that in the nurse's assessment, in the information from that facility, there is mention of symptoms, or there are perhaps a couple of medications that don't seem to have a correlating supporting diagnosis. But they're one of those 3 in this item. That's when you need to go back and make a phone call. Excuse me, this patient is on glipizide. This patient has insulin, but I don't see diabetes. Can you please let me know? I need to have that confirmed. That's going to make it much easier for you if you look at all of that information so that you can contact the physician, someone in that physician's office, to confirm that you are correct and there is a diagnosis that's present and active and was missing. So that having done that, that makes it much easier for you to have full and accurate information inside the critical window. 5 days for a SOC, 48 hours for resumption. As part of the assessment, your clinicians are taking extensive histories. Family members are going to say to you, well, you know, I think my mother's a diabetic. Really? And what makes you think that? Well, the doctor told her not to eat a lot of sweets, and he said this and he said that. So now you have more information. Perhaps they're not taking any medications, but the family's telling you she's been following this diet for a couple of years. It's not listed on any paperwork. Now's the time to make a call. It may be that the physician's been telling them that because there's an extensive family history, and it's not an active identified diagnosis, just a precautionary diet issue. That would not be included. But if the physician or the APRN or the PA says, oh, well, yes, that the A1C was borderline or it was just a hair above. And so we've started encouraging them to follow that diet so that we can keep it under control early. You need to get them to commit. Either this person is a diet-controlled diabetic or they're not, so that you know whether or not you can include that as an active diagnosis. Once it's been communicated verbally, you need to document it in the record. You need to add it on to your orders, add it into the OASIS, and remember that it has to always have come from someone who is an approved, allowable resource according to your licensure regulations in your state. How do we know if something is actually an active diagnosis? What defines that? What makes it active as opposed to inactive or not relevant at this point in time? An active diagnosis is one that has a direct relationship to the plan of care. It needs to be influencing the patient's current functional, cognitive, behavioral status, the medical treatment, something the nurse is monitoring, or presents a risk of death at the time of assessment. You should not be including diseases or diagnoses or conditions that have already been resolved and cleared. As I said before, this is the list. This is the place where you're going to look for this information. As you're creating that 485, whatever you're using for your physician's orders, as you're completing the OASIS, you want to look at every diagnosis that you have on all that information and confirm, how does this relate to the focus of the nurse's activities? How does this relate to the assessments she will do of their physical, cognitive, emotional, psychosocial, behavioral status, the things that she needs to closely watch to ensure their safety and that they improve? Making sure that you've always confirmed that with a licensed person. We've talked about the assessment window. What if you get the information after the assessment completed date? You started this assessment, you admitted this patient on today. Today is the 16th of November. You have 5 days. On the 22nd, somebody calls in and says, oh, by the way, I just remembered. That's outside the window. What are you going to do? You're going to accept that? Are you going to edit and add that in? That's correct. You're not going to do that. The OASIS data set cannot be revised to reflect this new information. It was not known and it was not documented in any of that paper that you got. It was not yet known, not yet documented at the time of the assessment, within the 5-day window for SOC, within 48 hours for resumption. What if you discover that a documented active diagnosis, active documented diagnosis, both criteria are met, was not indicated on the OASIS data set when it was marked completed at the end of the 5-day window, at the end of the 48 hours? What are you going to do then? Are you going to accept that? I see a lot of heads shaking no. However, remember the two criteria. It is both active and documented. Because it was both active and documented, you will be able to go in and revise the OASIS data set. You should be following the instructions in the Survey Insert Memo number 1518. That will give you the instruction on how to revise it and what to do. But remember, you must have a situation where you are meeting both criteria. It was active, relevant to the plan of care, and it was documented inside of those time frames. So let's look at the item itself and talk a little bit about how we are actually going to go through the process of answering these questions. You would select response number 1, peripheral vascular disease or peripheral arterial disease, if you know and have documentation that the patient has an active diagnosis of PVD or PAD. You would see that, and it would be coded with a code that begins with 170, starting at 0.2 and going all the way to 0.92. You can see the list is there, and it gives you all the different diagnoses. PVD or PAD is also indicated by the diagnosis code that starts with the first 3 characters, 173. I feel like I should be saying bingo. All of these numbers, you know, and I can't really read them very well. I don't know where in my trifocals I should be really looking. So now that we have dealt with those two, and note that there are two together in that first line, response number 2 addresses diabetes. And the question asks you whether or not this patient has diabetes, and you're going to check off number 2 if they do. And here, diabetes is indicated by any of the following diagnosis codes that start with the letter E, number 09, 08, 09, all the way up through 13. Okay, as I said, I'm not a coder. Now, they've given us some fairly specific instructions. Once your assessment is completed and it's determined that you do not have a diagnosis, an active, documented diagnosis for diabetes, PVD, or PAD, both boxes should be left unchecked. You need to make sure that internally in your agency, you have looked at how you are going to audit the documentation to ensure that this item is being completed accurately and correctly with the appropriate documentation on file as part of the comprehensive assessment. The question has been raised. If you look at the Q&A on the CMS website, question number 6 specifically says, how are you going to know if this was actually assessed, or if the clinician simply missed this question and skipped right over? And the response clearly states that it is the responsibility of the agency and your internal auditing and review systems to ensure the compliance, to ensure that, in fact, this has been reviewed, that the clinician did or did not have complete, accurate documentation of an active diagnosis. And if it's not there, it's not there. And so then in that case, both of those boxes are going to be left blank. In this situation, you're not going to simply put the dash in just to fill the box. Remember, the dash is new to us in home health, and we do not use this unless we have a situation where the item absolutely could not be assessed. This is most often going to happen when this patient has been unexpectedly transferred inside that 5-day assessment for SOC, inside the 48 hours for resumption. It's happened. In home health, most anything can happen. Those of us who've been at this so long know that that's what happens. They turn around and go back to the hospital. They get discharged. They refuse to let you back in before you've completed the assessment. Those are the times when a dash might be used, but they should be a very rare occurrence. Remember these tips. You need to have specific documentation in the medical record from a physician or anyone from that long list of approved, licensed individuals, according to your state licensure law, that this condition or disease is an active, confirmed, documented diagnosis. So that if the physician writes in his or her assessment that the patient has inadequately controlled diabetes, erratic blood sugars, requires monitoring and adjustment of the medications, you have now met the criteria that this is an active impact on the plan of care and it's a documented diagnosis. So you can only include the diagnoses that are clearly well documented and active. You don't want to be caught inferring. In other words, if a patient has in the list that they have weight loss, this is not necessarily malnutrition. There are lots of different reasons why someone might have sustained a weight loss that aren't necessarily malnutrition. They might have had a single episode of a shockingly low blood sugar. This does not make them an active diabetic, and that does not make it an impact on the plan of care where the nurse is assessing the patient's physical, mental, emotional, cognitive status for the impact of diabetes. So don't infer. Look for a specific, accurate, active, documented diagnosis. Let's practice a little. This is the way I check to make sure I didn't put you all to sleep. Which would make me really upset. I would feel really badly because everybody else has done such a good job and you've all been really interactive and I got to come last. That's a bummer. And you're not like my students, where I have a little more control. I can sort of, sit straight, pay attention, look at me. I get to grade you. Remember that? It's much more fun. I'm such a control freak. I really like that a lot. So here's our first practice scenario. Your patient, Mr. A, has been prescribed insulin for diabetes. He does require regular glucose monitoring to ensure that his blood glucose goals are being achieved by the current medication orders. The physician progress note that you've received clearly states the patient has diabetes, but does not list PVD or PAD. So how are you going to respond to 1028? Are you going to check 1, PVD or PAD? Are you going to check 2, both? Or are you going to put a dash in? Gee, I wonder how that happened. That was pretty well directed, wasn't it? It's sort of subtle. He has diabetes. No, he doesn't have the other two. Really. So let's take a look at a second one and see how that works. Here's the answer. We already saw that. Everybody got it right. Did I scare you? Is that how that worked? Diabetes would be checked, and it is an active diagnosis because the physician progress note supports that the patient has diabetes and that there is a requirement for ongoing medication management and glucose monitoring, so that you would fill the box just as is shown there by checking diabetes, but not the upper box for PAD and PVD. Here's your second patient. Mrs. I had a below-the-knee amputation. She had gangrene associated with PVD. She's been referred to you for dressing changes to the stump and monitoring for wound healing. In addition, the orders include peripheral pulse monitoring. The nurse practitioner, in her progress note, has documented the PVD and the left below-the-knee amputation. How would you respond to 1028? Would you say 1, PVD, PAD, 2, diabetes, C, both, or D, enter a dash? You have your clickers on your table. Okay, find your clicker, enter something in there. Hey, look at that. You're doing such a good job here. I know you're all anxious, right? There must be cocktails somewhere and you got to get right through this. There's the answer. But let's think about this. We are checking the first one because we have an appropriately licensed individual, the nurse practitioner. She's documented in her progress note that the patient has PVD, that there was an amputation related to it, and the nurse's orders include the wound care and the peripheral pulse monitoring. So we know that we've met all the criteria. It was an appropriate person, it was in the progress note, it's in the orders, so it all fits. We're not going to be this clean, cut, and dried, right? I mean, when does it ever get this easy other than in a practice scenario? It doesn't. I understand that part. I spend hours. I've spent most of the day up in the back corner combing through other people's clinical records, trying to help them to understand these things. It's not going to be this clean and easy when you go back. So yes, you can use these practice scenarios with your staff, but an interesting exercise will be to take a week's worth of referrals, pull out a few with or without these diagnoses, and then use those for your own practice scenarios. Because you need to be sure that in the real world, not here where it's clean and cut and dried, but out there in the real world, you're teaching your staff, teaching your intake department, teaching your compliance people that this is what you need to do. You're going to run your finger down the list of diagnoses in the transfer summary. You're going to run that finger right back down the list of meds. Better yet, put them side by side on the desk and draw little lines back and forth. And when you got a missing soldier, then you know that you need to make a phone call. You know who you need to talk to, because you've got to confirm active diagnosis, confirmed in the documentation. When it's not in the paperwork you received, when you've made a phone call and you've spoken to someone in the office, how are you going to document that? You want to think about what you want to do internally in your practice, in your agency. How are you going to add that to the documentation? Think about a process, get it nailed down, and put it in place so that you will know that your staff are going to have something to fall back on. And if you're asked, you will be able to show, I reviewed the paperwork I had, I got this additional information, and here is how I made it documented. So having dealt with that first new item, let's move on to another interesting little topic. We're going to talk about 1060 height and weight. Now, I'm standing up here, I'm looking out there at you, and I would say that maybe 75% of the people in the room are women. So how many of you are going to stand right up and fess up to the doctor or to the home care nurse, this is how much I weigh? Not happening. Unfortunately, it's happening. Height and weight. So why do we need to know this? How does this impact on the risk of pressure ulcers? What does this have to do with increasing the patient's risk of getting them, with increasing the risk that they're not going to heal properly or that they're going to get worse? How do these apply? This is what the item looks like. The expectation is that you're going to record the most recent height and you're going to record the most recent weight in the last 30 days. You're going to do this in a fashion that is consistent and according to standard agency practice. Do you have a standard agency practice at this time? I'm not seeing a lot of heads going, oh yeah, sure, no problem. Because most of us don't. And so for that reason, you're going to need to think about what you're going to do. That is one of the biggest tasks you'll need to tackle when you go back, is doing the research and establishing standard agency practice for height and weight. These two items together, the reason they've been added is because they support the calculation of your patient's BMI. Height and weight together, with a little math, are going to give you a BMI, which is going to give you the risk factor that directly affects the patient's risk of developing or having a worsening pressure ulcer. So why is that? If the patient is grossly underweight, possibly malnourished, that diminished nutrition and hydration can very easily create a situation of debility that's going to adversely affect the patient's ability to heal a wound. It will increase their risk to develop a pressure ulcer. The height and weight measurements are going to help your staff to determine the patient's nutrition and hydration. They're giving you a mechanism to monitor the stability of the patient's weight and BMI over a period of time. While this is a significant issue in determining the risk for pressure ulcers, there's no way to escape that this is also critical when you look at another one of the 4 primary causes for readmissions. Reducing readmissions is something near and dear to my heart. I spend a great deal of time trying to convince staff nurses, clinicians, therapists, they must weigh their patients. Patients with any type of cardiovascular disease must be weighed. There are a million ways you can think of. If the patient doesn't want to know, have them face you instead of looking at the number down there on the scale. Silence the little voice on the talking scales. Tell them over and over, I'm not interested in what the number is. I'm really only interested in how much it goes up or down, because that's going to tell me how well your heart's functioning. It's going to tell me how well you're using the food that you're taking in every day. Try whatever approach you need, but please get a number, because you need to have a number in there. We're going to be collecting this information at start of care and at resumption of care. So how are we going to do this? How are you going to go about measuring height? Again, according to your agency's standard policies and procedures and your standards of practice. For example, with or without the shoes on. Standard practices, shoes are off. Barefoot or in stocking feet. And of course, the first response I get is, well, what about the amputee? There's an answer to that question. There's an answer in the Q&A, and we're going to go over that shortly. You're going to measure and record the height in inches, because the tool has been set up in inches. When you report the height on a person with a bilateral lower extremity amputation, you're going to measure and record their current height after the bilateral amputation. If you're calculating a BMI, think about this logically. You're calculating the size of the engine that you're feeding, right? So if they tell you I'm 6'1", and you're looking at a bilateral AKA, not anymore, you're not. And the size of the engine that I'm feeding is the size of what's in front of me. Ask them to lie down on their bed. Measure them crown to the end of the stump. You need to measure exactly what you have in front of you. You're going to complete this for a reason for assessment, MO100, number 1, start of care, or number 3, resumption. You need to use the nearest whole number. Therefore, we use mathematical rounding. Do you remember that? That's about the level of math that I finally succeeded in. 0.5 and up goes up, 0.4 and under goes down. What about the weights? Save that for last, because it's a really touchy subject. Again, it's measured in accordance with policy and procedure and reflecting current standards of practice, which means unless you've already addressed this in your agency's policies, you've got homework to do. You need to go back and look. What are the standards of practice? What is a verifiable, validated resource that you can cite to say this is how our staff is going to go about this and this is the why? That's something that you do need to do. CMS has given us an option for the patient to absolutely cannot be weighed. They have extreme pain with any movement. They're immobile. They're casted, braced, in traction, whatever. Or they have a high risk of pathological fracture. In those situations, you will be allowed to use the dash. Again, as with height, reason for assessment, number 1, start of care, number 3, resumption. The mathematical rounding applies. 0.5 pounds and up goes up. 0.4 pounds and under goes down. Personally, I take it down no matter what. If I'm talking about me, it's going down. Again, a dash. When would you use a dash for weight? When the patient is unexpectedly transferred, discharged, or dies before the item can be completed. Within the 5 days for stock, within 48 hours for resumption. Again, if you have someone totally immobilized in the bed, you're going to need to put the dash there. They cannot, unless you've got a bed scale. If there is a weight within the preceding 30 days prior to the casting being put on, you could use that. But you need to look very carefully at the records and be sure that you are only using information that can be validated and verified, and that the dash is a very rare occurrence. So let's have another crack at one of those cut and dried scenarios. Your patient, Mrs. G, has congestive heart failure. She also has advanced osteoporosis. She is at high risk for those pathological fractures. At rest, on her bed, on the couch, in her chair, she's pain-free. But the moment she has to move, she's in excruciating pain. In fact, she's in such pain that the daily weights related to her congestive failure have been discontinued as part of her prescribed regimen in order to achieve pain management. Think about this. How are you going to respond to 1060? And what is your reasoning behind that? Are you going to try to make her stand up on a scale? Good for you. I'm with you. This would be coded as a dash. This patient meets the criteria for a dash. She would have high risk of the pathological fractures, and she's immobile due to the extreme pain of any motion. So here you would use the dash, but what did we have to add to that? If it's not documented, it's not done. So document clearly in the narrative somewhere that you were unable to obtain an accurate weight on admission, on resumption, due to, and list the reasons. That way you are sure when you're auditing this OASIS tool that your clinician had a reason for putting the dash in there, and it wasn't because they really didn't want to talk about that. So let's look at another scenario here. As part of the start of care assessment, the nurse has to obtain a height for Mr. B. Mr. B has had bilateral lower extremity amputations due to the complications of his diabetes. So I guess we know how we answered the previous one too, don't we? His legs are now uneven in length. Using a tape measure, the nurse measures his current height while he's lying in bed. She has two different measures, 64.4 on one and 60.8 on the other. Not unusual, right? We've all seen those things. So get your clicker and think about this. How are you going to enter this individual's height? 61, 64, 65, or with a dash? Can I go back? They were 64.4 and 60.8. So how are you going to do that? We have about 15 seconds left. Is it A, B, C, or D? I need one of those clocks. 3, 2, and the correct answer is 64. The longer limb was 64.4. You rounded down to 64, and you selected B and entered the total height as 64.4. And that's the rationale. Even though they were uneven, you're going to use the greater length as the patient's height, and you're going to round using the mathematical rounding. 0.4 and under goes down. So 64.4 as the longer length was rounded down to 64 and is the correct answer. Let's try it again. During a start of care assessment, a nurse completes her comprehensive assessment. Your agency's policy states that a patient's weight is to be obtained with the footwear removed. The nurse helps the patient to remove his shoes and obtains his weight. She records that weight as 126.8. So now, how are we going to answer 1060B, the patient's weight? You've got your numbers there. Pick up your clicker and pick one, remembering what the number was. Okay, are you rounding up or rounding down? Okay. Has everybody got their entry in? And the correct answer is, it's C, 127. And why is that? It's entered as 127 pounds because we rounded up, it was 126.8, and the nurse did obtain the weight correctly by asking the patient and helping him to remove his shoes in accordance with standard agency policy. That's going to bring us to the final item in the covariates. This one is a review. This has not changed and it's not new. We're going to take a quick look at bowel incontinence frequency. The intent behind this is for you to identify how often the patient is experiencing some form of bowel incontinence. We are referring here to the frequency that this occurs, not to the cause. You're interested in the cause in terms of diagnoses and how it affects the plan of care. But you're going to be documenting and answering this question in terms of frequency so that you will know how this is going to impact the pressure ulcer risk. We're not addressing the treatment either of incontinence or constipation. That would be a bowel regimen, and the presence or absence of a bowel regimen is not relevant to how you answer this question. The time points are different for this. For the preceding two covariates, you were collecting the data at SOC and ROC only. Here, we are collecting this information at all four of these time points. We're interested in start and resumption, the follow-up, and the discharge from an agency when not to an inpatient facility. This is what the item looks like in the OASIS tool. You are able to code this from 0 to 5 with an option for NA for the patient who has an ostomy for bowel elimination. So when you go about doing this assessment, it's going to be done as part of the interview process in the health history. You're going to be asking questions about a very sticky, personal topic. So consider your audience. Try to give the patient as much privacy as possible. When we look at answering this question, You want to go back and take a look at what is your standard of practice for how the interview portion of the health assessment is done. One of the classes I teach at the University of St. Joseph is performing the health assessment. When you've got a lab full of 19 and 20-year-olds, and I hand them the list of questions, they get to this one, and if I'm not within earshot, trust me, everybody's normal and nobody's asking. Because nobody wants to ask. And so I will then go back and make them ask. I make them say the words. You could have nurses on your staff that have been out there doing health history interviews for the last 5 or 10 years, who may very well not be asking if your patient has ever had a bowel incontinence problem. They're not going to say, are you having a little accident? Do you ever leak a little? They're just, you don't have any problems with your bladder or your bowels, do you? You know, we got to get right over this question really quick. You know, it's right up there. When the last time I was actually in the hospital, which given this little appendage of mine is a fairly regular occurrence, I was getting ready to leave. And I'm not going to tell you how old I am, not. But the intern, who I swear to God looked young enough to be my grandson, is sitting there fidgeting in his chair because he's got this long list of questions and he's got his preceptor breathing down his right shoulder. He gets to this one question, he hems and he haws, and he sort of looks down at the floor. And he's not asking me about bowel and bladders, he wants to know if I'm sexually active. And I looked at him and I said, it's okay, honey. I'm old, I'm not dead. I couldn't resist. He was absolutely purple. He blushed so hard. And think about your nurses. What are they asking when they get out there? Are they seriously going to ask a 45-year-old man if he occasionally leaks when he doesn't make it to the bathroom before he passes gas? They're not doing it. Look at your policy and your practice for taking a health history interview and make sure one of the best competencies you can do is to actually make them partner up and don't let them pick their own partners. Okay? Names in a hat. It's what I do with my students. It's a great exercise in and of itself. Put all the names in a hat, everybody picks a new partner, you pair up in the conference room, here's your health history, now take one. You won't be really popular for a few days, but hey, it will be very entertaining, and they will learn to take the history the way it needs to be done. They need to ask these questions. We ask our patients as part, I hope, as part of the Oasis Walk, to show me how you get up and on and off the toilet. Show me how you would step in and out of the shower. Can you get your leg over the side of the tub? And the answer, by the way, is yes, I can. But while they're doing that, that's when they have the opportunity to look around the bathroom. Check it out. Are there any little spots and stains? Are there some extra underwear in the corner or in the hamper? Is there a ripe little odor somewhere? They need to observe the cleanliness, look for soiled clothing. If there's a home health aide involved, they should be asking the aide, what's in the laundry when you do the laundry? Is there stained clothing? Are they changing their clothes 3 times a day? You know, and it's not an emotional or behavioral issue, it's some other issue. So we need to be asking. There are lots of ways to phrase the question, but it's not acceptable to not ask the question. So that brings us, at long last, down to the end. We're going to summarize a little bit. The quality measures for pressure ulcers that are new or worsened has multiple covariates that affect the risk adjustment. We've talked this afternoon about active diagnoses, the comorbidities and coexisting conditions of PVD, PAD, and diabetes. We talked about height and weight and the impact these are going to have on the patient's ability to heal an ulcer. We've talked about bowel incontinence, briefly, gets a touchy little subject. And Anne has helped us to understand how we need to assess the patient's ability to move, to safely and with what degree of independence go from lying in the bed to sitting squarely on the side with or without assistance. 1028, 1060, and GG0170C are new to the OASIS C2. So they're new to you and to your staff. You need to prepare training. You need to think about how you're going to go about training, assessing competency, and making sure that your staff are ready for these changes. And even though there's no change to 1620, take a hard line look at how they're conducting that health history interview, because I would be willing to guess they're not asking everything that needs to be asked in the way that it should be asked. Go back to your agency. Look at your policies and procedures, your standards of agency practice for height and weight and documenting active diagnoses. Create an education plan for the clinicians to deal with each of these new C2 items. Practice coding, entering the data into an assessment tool with your staff. You're welcome to use the scenarios that we have given you today. You're welcome to create your own from your own patient records or from your own fertile imaginations. But you do need to practice, 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 and make sure that they are competent in accurate data collection. There are some resources here on the last side, and we will be here for a little bit. We still have some time left in our calendar for today. Do you have any questions for me? If you do, please go to the microphone so that we can share those questions with our audience that's out in their offices, because I know you're all hanging in there with us. Yes, ma'am.
My name is Adora Nora from KOC Home Health.
Mm-hmm.
We have a situation where in the clinical notes from the physician, a diagnosis was mentioned, but there was no medication that supports the diagnosis. Can that still be used as an active diagnosis?
There was no documentation to support it.
There was the documentation in
there was?
Yeah, in the physician progress notes,
Mm-hmm.
but there was no medication to it.
Then in that case, you would want to be calling the physician and saying, in your progress note, you listed this diagnosis. What is your treatment plan?
Okay.
Because we certainly don't want to say, oh, by the way, did you forget to order the meds? But we definitely need to know. We need to confirm one way or the other. Are there going to be medication orders to go with this diagnosis?
Okay. Then my other questions. I just brought up the idea of medication, but when you were talking about the active, we said it has to be documented and it has to be active.
Mm-hmm.
So medication is part of that documentation.
It may or may not be. The example I gave, for instance, and my mother was one of those diet-controlled diabetics. Her hemoglobin A1C was right on the borderline. And so for a number of years, her physician he was old-fashioned, he didn't like the term pre-diabetic. So he instructed her to follow a specific diet. He did not give her medication, but he considered her to be a diabetic. So when I received her discharge paperwork from the hospital, it listed her as a diabetic with no medications.
So in that case, diabetes can still be used as active?
Yes, ma'am.
If there's no medication provided?
That's right. Because the nurse who came out to the house was in fact checking her blood sugars, and she was still having lab work done every quarter for the hemoglobin A1C. So even without medication, it was impacting the plan of care because the nurse was assessing. Okay?
Okay. Then how do we select for follow-up care, active diagnosis for a follow-up?
You're going to be looking at what was the patient referred to us for? What is the reason that the patient is going to be receiving home health services? What is it that the nurse is going to be focusing on, the nurse and or the therapist? What are they assessing? What are they documenting to? What are the risk factors for this patient? These are the criteria. When you go back to that previous slide, you'll see that what it says to you is, what is it that the clinician is looking at that affects the patient's functional, cognitive, behavioral, emotional, psychosocial, risk of death, risk of injury. These are the things that the nurse any one of those. If the diagnosis is there, with or without meds, and that diagnosis is going to affect the patient's status in any one of those areas, then it's an active diagnosis. If you have medications or symptoms, the patient says, I have these spells. Really? Tell me about those. Well, if I haven't eaten for quite a while, I'll get really sweaty and dizzy, and I'm so tired, and I even passed out once. That walks, talks, and smells like a diabetic to me. But it's not on the list, and it's not in the meds. I would be on the phone to the physician. I'd be reporting it. I'd be asking, can we get a fasting blood sugar? I can make the arrangements. What do you need? You need to work really hard in a situation like that to get the information. It's a situation where you may not have the answer inside the 5-day window. So you might not be able to check it off, but at some point, you will be able to indicate that the patient has now been newly diagnosed. Okay, so do you see how that fits? Even if you didn't get the answer within the 5 days, you still need to track down the symptoms, the complaints, the history that the family gave you. Mom says, I feel fine. Nope, no, I don't have any bad spells. And the daughter tells you, if she doesn't eat breakfast and I get here, but at 10:30 or 11, she's sitting there and she doesn't always know who I am and she's all sweaty and I give her some juice and she's fine. Well, there you go. It makes sense. You may not get it in the 5 days or the 48 hours, but keep chasing it down because it's part of our obligation. Anyone else? Yes, ma'am. You need to go back and read the Q&A carefully. Right, but there was, I did see an instance where they mentioned it. Mm-hmm. Mm-hmm. Okay. We can verify that. We have CMS people here with us. I will verify that. I may have misread it. Okay? But we do want to try to get whatever information we can. Yes, ma'am. Right. Yep. Right. Right. We'll try to get that clarified for you. These lights are killing me.
Sorry. I'm Grace,
Yes, ma'am.
with Grace Compassion Home Health. My question is, and it's probably related to the same thing, if you can't measure the weight, and the client is not able to stand, the question is can we use the mid-arm circumference, the mid-upper arm circumference? Is it acceptable if the doctor says it's okay to use it?
There are two different topics there. You would not be using that to give you height and weight. Okay, the upper arm circumference is not going to give you the weight, but you could use that elsewhere in your plan of care.
So we could put that in a narrative.
Right, it is not going to give you an answer for the OASIS tool.
Okay.
The upper arm circumference is not going to give you an answer for the OASIS tool because that's calling for height and weight in inches and pounds. So, but as part of a clinical plan of care, which is a totally separate topic from what we're talking about today, you would be able to use something like that. I do teach people to look at alternate ways to measure fluid retention for congestive failure, but that would not work for answering this particular question because they are specifically asking you for height and weight in pounds and inches.
Okay, so we
Okay.
just put dash.
You'd have to go with the dash. Okay, we have about 5 minutes left. If there's anyone else. Okay, on the web, they missed the first half. The young lady was asking if the patient is absolutely unable to stand or to be weighed, that could she use an upper arm circumference to answer that question? And the answer to that would be no, because they are asking you for height in inches, weight in pounds. And upper arm circumference could be used as part of the plan of care, but not to answer this question in the OASIS data set. Okay, we are talking about two totally separate things. Answering that question for height and weight is pounds and inches. Creating the clinical plan of care is a different topic, which is not one we're supposed to be working on today. But if you are looking for a way to continue to assess the presence or absence or the degree of congestive failure or a patient's nutrition and hydration, that's a separate issue, and I have seen it used in that way. Yes, ma'am.
Hi, I'm Andrea Manning from Manning Healthcare Group in Talkeetna, Alaska. And
Whoa.
my question,
You get the prize for coming the farthest. Can anybody beat that?
thank you.
Welcome, welcome, welcome.
So I'm going to take all this information back to the 13 agencies that we have in the state.
Good for
Only
you.
13 in the whole state. But my question is, we were talking about in the height and weight, it's based on your policy. There's nowhere, I know in seeing documentation for years, we get these stated weights, stated heights. Like you were saying, you're no longer 6'1". So is that strictly based on, nowhere in this documentation or in what we've learned today does it say that they must physically do it. I know that's best practice. So this entire thing is based on what you put, what your organization policy is in how you obtain that information.
No, if you go back and look at the slide carefully, it
Okay.
says that the patient is to be measured and weighed as part of the assessment.
So they can't get out
are-
of it by just giving you a weight
No,
from the doctor's
no,
office.
believe me, I tried.
Right.
Nobody wanted to buy that. I don't know why. Don't I look like I weigh 95 pounds? A girl can dream. Okay, anyone else? Clock ticking. They're giving me that high sign. I have 4 minutes. So, anyone else? No? All righty then.